Acquisto. I'm a senior vice president with Appriss Incorporated in Louisville, Kentucky, as you can tell by my accent. Glad to be here. We operate the NPLEx system in the 35 states that mandate it by law and the 2 states that have a voluntary program, California and New York. 80% of the drugstores in those states contribute to the system. This law is, well, let me go back. I retired from law enforcement, did 24 years full-time and worked my first meth lab in 1997. So I've been working on this subject for about 20 years. Helped write the Kentucky statute that made it against the law to have pseudoephedrine for the purposes of making methamphetamine when there were no rules. We got 250,000 grams of pseudoephedrine out of a single lab. Those were the old days. Now it's different. Meth labs in this country are one pots about this size. The big labs that supply us all the high potency and high purity methamphetamine that we all see all over the country are all south of the border, in large part due to great law enforcement work and great regulations like the NPLEx law and others that have passed around the country. What happened was when Congress passed a law that took effect in 2006 called the Combat Methamphetamine Epidemic Act, they said they mandated all retailers of this medicine have to put it behind the counter. Any person that wants to buy it has to show ID. It has to be recorded on a manual log, and you can only buy 3.6 grams in a day, which is the largest box made, and up to 9 grams in 30 days, which gives a person enough to take a pill every day, which millions of folks do. The problem there was it was all manual, paper logs. People that use drugs and use medicines to make drugs they're addicted to are a very driven population. So guess what? They went from store to store to store to store and from state to state to state, as you might imagine. So we saw a need to make this digital, where actually it was a connected system. And folks much smarter than me that work at Appriss before I ever came to work there built the system that connected all this and made it real time. And that's the key. Real time is the key. So when I came to Appriss, we had the state of Kentucky and we had the chain of CVS drugstores across the country that had started using this system. As states began to entertain what should we do and saw the millions of pseudoephedrine pills that were being sold, even with the manual logs and the meth labs, it became evident that the footprint has to be large. You have to scale this information. It was fairly obvious to most of us that prescriptionizing it was not the best course of action because of the problem we have with prescription drugs. Same problem. I'm not going to second guess you guys on that. That's what you should have done back then. Didn't have the ability to do the things that we do now. So fast forward to where we are now. We are in 35 states by law. We get about 150,000 transactions in real time every day. The way it works now is you go into the store with your ID, just like you would anywhere. It's federal law, whether you pass anything or not. You show the ID in one of our stores. It gets scanned or swiped or even typed in if they want to. The product is entered immediately with a barcode, and in less than a second, we recommend a sale or no sale based on all the laws of the jurisdiction of where that store stands. So if they bought a box in a CVS in New York City today, and then they flew to Portland, Oregon and tried to buy another box, would have put them over the limits, a block is recommended. If it was across the street, a block is recommended. If it was in the same store and they came back through the line, a block is recommended. It has to be real time in order to do that. The information is required to be provided only to law enforcement. That's federal law. It doesn't go to anybody else. That's been the law since day one. So we built a real-time portal for law enforcement. They can actually see what happens in the store before the purchaser comes out. Frankly, it's better than prescription. You can't do that with prescription drugs. I don't know of any block sale mechanism in a prescription drug environment. I can tell you that we do this constantly to the point of 13, sorry, let me find my notes here real quick. We have tracked 414 million boxes since we started the system, and we've blocked 13 million boxes. Meaning blocked means the pharmacist or the clerk got a message that this would violate the law, and the medicine stayed in the store. It didn't go out and get turned into methamphetamine, but that information was captured for law enforcement if they decided that this person was violating the law. People that get blocked aren't always violating the law. Sometimes they're just innocent and they don't know there's any rules. So we let law enforcement have the information. They get to decide what to do. We've seen a huge drop in meth labs across the country. Indiana, in 2013, their high of 1,797 meth labs, according to the EPIC system that DEA is in charge of for counting methamphetamine labs. Last year, down to 144. So massive drop, less than 10% of the labs they once had. Ohio, a similar drop, a high of 1,010 110 meth labs in 2013, down to 60 last year. So these numbers continually repeat. Nationally, we had 13,567 meth lab incidents in 2011. Last year, 1,280. People aren't making meth in the United States anymore. They're making it south of the border. It's better. It's more pure. Yes, sir. What we've seen is 53,000 on average unique Oregonians go to other states, border states, and purchase pseudoephedrine every year for the last 5 years. Unique individuals from Oregon go and buy it. When they come back home, they break the law. But that's tax money and folks that have to come from your state to another state. And I want to finish now, and I'll leave it at that because of the time constraints.
Thank you.
Rep. Noble has a question.
I do too, actually. So you said that the only